Welcome to this explainer. Today we are zeroing in on streamlining the diagnosis and management of acute gastroenteritis, specifically tailored for emergency physicians and advanced practice providers. Now, if you work in the ED, you know that acute diarrheal illness is a daily, sometimes even hourly presentation. But despite just how incredibly common it is, our management strategies can really easily default to unnecessary testing and, quite frankly, overtreatment. So today we're going to fix that. We'll look at the latest guidelines to help optimize your workflow, protect your patients, and save some of those critical ED resources.
Let's kick things off with a pretty stark reality. Up to 90% of acute gastroenteritis is viral and totally self-limiting, with symptoms typically resolving on their own in the first 48 to 72 hours. Yet, despite this overwhelming viral etiology, acute gastroenteritis just continues to drive massive resource utilization, extended lengths of stay, and an endless amount of reflex testing in the emergency department.
To put this into perspective, just look at a recent study out of the American University of Beirut Medical Center. It revealed a seriously concerning trend. Over 26% of patients who are perfectly well enough to be discharged inappropriately received antibiotics. This really highlights a critical need across all of our practice settings for protocol-driven care. Because let's face it, when we just go off gut feeling, pun fully intended, we end up overprescribing.
So how do we fix this? Today's clinical pathway covers 5 key areas: triage and red flags, diagnostics, antimicrobial stewardship, disposition, and finally, key takeaways.
All right, let's dive straight into Section 1, triage and red flags, starting with that crucial initial assessment.
The absolute first step here, rapidly categorizing the illness. You have to figure out if it's non-inflammatory or inflammatory right out of the gate, because that dictates the entire clinical course. Think of non-inflammatory as your classic watery diarrhea. It's often accompanied by vomiting, nausea, and cramping, which is highly indicative of a viral or preformed toxin etiology. Inflammatory diarrhea, on the other hand, presents with bloody stools, high fever, severe abdominal pain, and tenesmus. This strongly suggests invasive or toxin-producing bacteria like Salmonella, Shigella, Campylobacter, or Shiga toxin-producing E. coli. Nailing down this distinction in the first 2 minutes is literally your golden ticket.
Beyond that initial split, you've got to keep a really sharp eye out for specific red flags on your history and physical exam. We're talking bloody diarrhea, symptoms dragging on for longer than 7 days, a toxic or comatose appearance, focal pain that suggests a surgical abdomen, immunocompromise, or severe hypovolemic shock. Finding any of these, that immediately bumps the patient out of the simple supportive care bucket and into requiring active, rapid investigation.
Moving right along to Section 2, diagnostics, where we really need to focus on targeted testing.
Okay, we need to completely bust the myth that every single patient with diarrhea in the ED gets a CBC, a comprehensive chemistry panel, and a routine stool culture. For mild, non-bloody diarrhea in an immunocompetent patient, lab tests add absolutely zero clinical value. Please do not order them. However, for bloody, severe, or prolonged cases, or those with specific outbreak exposures, we do need targeted testing. But traditional stool cultures are out, and culture-independent multiplex PCR is in. It gives you rapid concurrent detection of bacterial, viral, and parasitic pathogens, heavily streamlining your diagnostic phase.
And blood work? That is heavily restricted in this pathway too. You should only be ordering a chemistry panel to evaluate electrolytes and kidney function in cases of severe dehydration. A CBC and blood cultures? Those are strictly reserved for patients actually showing signs of systemic sepsis. And crucially, if you suspect Shiga toxin-producing E. coli or STEC, you must monitor hemoglobin, platelets, and renal function very closely to catch the early manifestations of hemolytic uremic syndrome.
I also want to highlight this very strong recommendation directly from the Infectious Diseases Society of America. I'm bringing this up because I know it's a hard habit to break for many clinicians. We have to abandon fecal leukocyte and lactoferrin testing. They just do not reliably establish the cause of acute infectious diarrhea. And honestly, sitting around waiting on those results just delays optimal care.
This brings us to Section 3, and honestly, the real climax of this explainer, antimicrobial stewardship.
This is a massive clinical and professional duty to protect your patients and the whole healthcare system. Simply put, do not treat empirically with antibiotics unless dysentery, meaning bloody, mucoid stools, is present. For non-bloody, watery diarrhea, antibiotics do absolutely nothing to shorten viral symptom duration, and they must be actively discouraged. Giving antibiotics for viral gastroenteritis is a major pitfall we have to avoid.
Now, when you absolutely must use empiric antibiotics, you need to stick to really strict indications. Severe traveler's diarrhea, suspected cholera, suspected shigellosis with high fever and bloody stools, or patients who literally present in septic shock. Even then, you've got to tailor your choice to regional resistance. For example, the CDC recently warned about extensively drug-resistant Shigella, which completely changes our go-to empirical choices. In hemodynamically stable patients who do need empirics, ceftriaxone monotherapy is often a really reliable first-line choice, while azithromycin can cover Campylobacter.
And this perfectly illustrates why stewardship is so crucial for protecting patients. Handing out inappropriate antibiotics for a viral case disrupts gut flora, sure, but it gets way worse. Giving antibiotics in unproven Shiga toxin-producing E. coli cases can actually trigger devastating complications like hemolytic uremic syndrome. So sometimes keeping that prescription pad in your pocket is the most active protective medicine you can practice.
Now you might be wondering, what about other agents? Well, antivirals are completely absent from these pathways because viral acute gastroenteritis is managed purely supportively. Antiparasitics also have extremely narrow use cases. For instance, nitazoxanide is considered for persistent giardia, or for cryptosporidium primarily in immunocompromised patients, like those with HIV. In healthy individuals, even these parasitic infections are almost always mild and self-limiting.
All right, let's head into Section 4, Disposition, where we figure out who stays and who goes home.
This all builds into your final clinical decision. Oral rehydration therapy, or ORT, is going to be your primary medical intervention here, not jumping straight to IV fluids. But it has to be a structured trial. First, assess their dehydration scale. Second, proactively give ondansetron if they're vomiting. Third, conduct a regimented trial of ORT over 30 minutes right there in the ED, having the patient or family use a syringe or cup every 5 minutes. And finally, reassess. Doing this the right way saves the patient an IV line and drastically cuts down on your length of stay.
So when is discharge safe? It's highly appropriate when your patient hits specific criteria. They need to be fully rehydrated or have only mild dehydration. They have to be successfully tolerating oral fluid intake without immediate emesis. They need to have passed urine in the ED or within the last 4 hours. There must be 0 red flags on exam, and they have to have an adequate safety net for follow-up.
On the flip side, you absolutely have to admit patients to medical or critical care units depending on their severity. Patients exhibiting signs of shock require critical care admission. Medical admission is necessary for severe dehydration beyond 9% of their body weight, intractable vomiting that fails that structured ORT trial even with ondansetron, a toxic clinical appearance, or those with high-risk complex medical histories like immunodeficiencies or significant renal or cardiac disease where sudden fluid shifts could be really dangerous.
Let's wrap things up with Section 5, Key Takeaways. Just a quick summary before we go.
We've covered a ton of ground today, but if you remember nothing else to streamline your workflow on your next shift, lock in these 4 pillars. 1. Acute gastroenteritis is overwhelmingly viral. 2. Diagnostics should be heavily restricted. No more reflex chemistry panels or stool cultures for watery diarrhea. 3. Avoid empiric antibiotics entirely unless you are staring at dysentery or a frankly septic patient. And 4. Structured oral rehydration therapy, combined with antiemetics, is your absolute best tool.
By ditching the reflex to just order broad panels and inappropriate antibiotics, you are practicing high-value care that protects both the patient and the healthcare system. You have the guidelines, you have the evidence, and you definitely know the risks of overtreatment. So looking ahead to the next time you walk into the emergency department, will you be changing your standard orders on your next shift?